Hello, everyone, and welcome to this ISHA live surgery broadcast. We have a great presentation for you today. I'm Andrew Jimenez from New Haven, Connecticut. We also have moderating Dr. Frederic Laude, and of course, our surgeon, Dr. Benjamin Domb. Today's case will be arthroscopic management of hip instability and painful internal snapping in the young female athlete. Dr. Domb, you want to give us an introduction to the patient?
Great. Thanks very much, Andrew. Thank you, Andrew, and thank you, Dr. Laude, for both of you being here with us today, virtually in Chicago, where we will be under the epicenter of the solar eclipse here in just a couple hours. Also thanks to our staff here, Brittany, our scrub tech, Nancy and Megan, our nurses, Dr. Ben Coons, who has been our fellow at American Hip Institute and continuing on as an attending here at American Hip Institute, and Ali Mack, our physician assistant. So hopefully between them, they'll help me figure out what to do with this case today. It's an interesting case and one that I picked for a couple of reasons because I think there are a couple points of discussion about it. This is a young 17-year-old female with instability of her hip and painful internal snapping. She has had pain for a year or so, has failed to improve with conservative measures for over 3 months, including physical therapy, anti-inflammatories, and activity modification, and hence has come to the indication for arthroscopic treatment. So if we can spotlight the x-rays for a moment, we can talk about the x-rays. Here you can see a AP pelvis standing on the top right and, supine on the top right, standing on the top left, standing on the bottom left, bilateral done view on the top left, and a false profile view on the bottom right. So she has a center edge angle of 28 degrees on the x-ray supine. On her CT, which I'll get to, that center edge angle was 25 degrees. And slight cam morphology. Overall, I would say, however, that she has somewhat of a low volume acetabulum. So although she does not meet strict criteria to be considered dysplastic, given the center edge angle of 28 degrees on the supine x-ray, I do feel that she has somewhat of a low volume acetabulum if we look at the anterior and posterior walls. Let me pause there for some commentary on this case from Dr. Jimenez and Dr. Laude, who respectively have written tremendous amounts. Dr. Jimenez about iliopsoas lengthening and painful internal snapping. Dr. Laude extensively about treatment of instability, including both osteotomies and arthroscopic treatment. So I'm very privileged to have them as our experts here today for this case.
Great. Yeah, thanks for having us. And just for everyone to know, there is a Q&A function that you can use in the Zoom at any time to ask questions, and we'll relay those to Dr. Domb for live responses. Seems like a perfect case from my standpoint. In terms of evaluating the images, some of the views that you use or some of the angles that you use for evaluating coverage, I know LCA, ACA you published on. Does 3D imaging play a role when you evaluate these patients?
Certainly. And why don't we actually move to that? So if we could spotlight the CT scan. So here we have a 3D CT scan. And a nice thing about these 3D CTs is we can rotate the image in space. This particular software gives us a color coding of where it deems to be, where it deems to have impingement, and that's based on averages of bony morphology, both acetabular and femoral. And then we can look at some specific measurements as well. I like to look at it in this form. Some interesting things to highlight. The acetabular version is 14 degrees at 3 o'clock, 3 degrees at 2 o'clock, and 1 degree at 12 o'clock. So not a retroverted acetabulum. perhaps a little bit of an overly anteverted acetabulum. Another interesting thing to look at is the acetabular coverage, which comes as a percentage. So that's 55%, which is on the low end overall. And then lastly, a measurement that I find very helpful is femoral antitorsion, which is 15 degrees here. So that puts her in about an average realm. But if you have femoral retroversion or excess anteversion, that may change our thinking about impingement versus instability.
You don't calculate anything about the ankle tibial torsion, no?
About the tibial torsion?
Yeah, now I do that regularly. It's sometimes surprising, but
yeah. So we've done that only when we've clinically detected abnormalities in version one way or the other. So clinically, we've used the thigh foot angle and, of course, internal and external rotation. But I do think it's a very important measurement to account for, particularly if we think there are rotational abnormalities. Totally agree.
mm,
Yep.
Then in a case like this, I think. Sorry, go ahead.
Go ahead. Yeah.
A case like I think a lot of people are probably interested in the indications for the iliopsoas lengthening. If you can kind of walk through your evaluation in the clinic and how you indicate that.
Definitely. So that was one of the reasons I picked this case, which because iliopsoas lengthening has become somewhat of a controversial topic in our discipline, in our field. And aside from being an incredible surgeon and an awesome guy, one of the reasons I thought you'd be a great moderator, Andrew, is having written about iliopsoas lengthening and where its role fits in. So there are a variety of very good surgeons who have published very conflicting findings on their treatment of iliopsoas lengthening, and all of them are telling the truth. They've just simply had different experiences. So some surgeons have had experiences where iliopsoas lengthening or iliopsoas releases perhaps have caused weakness or have aggravated instability. Some have even had experiences where dislocations have followed iliopsoas releases. Our approach at American Hip Institute has been to avoid iliopsoas releases in cases of painful internal snapping with iliopsoas impingement detected arthroscopically. We've done iliopsoas fractional lengthenings. And I think a couple of the things that are specific about our approach, one, we do not extend the capsulotomy at all, so I'll show that. Two, we do the lengthening about 5 or 6 centimeters proximal to the lesser trochanter, really above the level of the joint line, so that it is actually a lengthening rather than a release. And third, we've placed a huge emphasis in these cases on the fact that we're treating instability. Most cases of painful internal snapping are instability cases. And our thought has been that if the instability is not fully treated, then the patient can actually get worse. The hip can get worse. But if we treat the instability fully, then we can restore stability through the static stabilizers, including the labrum, the capsule, and perhaps the ligamentum teres. And in that setting where we've restored stability, then the iliopsoas no longer is a stabilizer. Its action as a stabilizer was a pathologic situation where it became a secondary stabilizer. Where we've restored primary stability, then it no longer needs to act as a secondary stabilizer, and then we can perform an iliopsoas fractional lengthening. And our data has shown very high level of success in treating the painful internal snapping in that way without the incidence of weakness or aggravation of instability. So with that said, I'll sort of start the case, and we can have some more discussion about that point as we go. I'm sure it'll be a point for lots of discussion. So if you can zoom now to the outside view, I see you're on it. Thank you. We have created an anterolateral portal. Let's put on traction. We've created an anterolateral portal here, a mid-anterior portal, and a distal anterolateral accessory portal, or DALA portal. So far, I've created a capsulotomy, an interportal capsulotomy, and I've placed a traction stitch here in the acetabular side of the capsule to elevate it off of the labrum. So let me have a switching stick and a half pipe. I'll take you through a diagnostic arthroscopy here. Yes, go ahead.
Then may I ask a question? In your practice, on 100 cases, which are impingement, instability for hip scope?
I'm sorry, I couldn't fully understand the question. There are cases where it's
how many percent of your case are instability, cam impingement, femoral acetal impingement? Do you treat more instability or more cam, or more femoral acetal impingement?
Yeah. So the question being, what percentage of my cases are instability versus impingement? There is clearly a very large overlap between the two, and that makes it hard to answer the question exactly because there are a lot of patients who have both instability and impingement, and I think this is one of those patients. I think she has a degree of cam impingement. If I had to rate which is the more important factor in her, I think instability is probably playing a bigger role, but clearly both are playing a role. So I think of it like a Venn diagram with overlapping bubbles between instability and impingement. What about you, Fred?
No, it's the same, more and more instability, and I agree with you. Sometimes it's completely mixed, and it's not so easy to find which is the culprit.
Yeah, for sure. Well, let me take you through a diagnostic arthroscopy here. We'll begin with the ligamentum teres. The ligamentum teres, I believe, is intact in this case, which is a good sign as far as instability, because when instability becomes more progressive, then we start to see traction-related tearing of the ligamentum teres. So that's a good finding. She's 17 years old, so I wouldn't expect an osteophyte, but there is a little bit of what might be the early beginnings of osteophyte formation here and here. This is, note, a soft tissue mass, but I think we'll remove that little bit of soft tissue from the border of the notch. The labrum is seen here. There is an iliopsoas impingement lesion here at the psoas U, and that's quite damaged. And then here you can see this blush on the anterior superior part of the labrum. We also see a fairly significant wave sign, especially at the iliopsoas U, and then reaching a little bit more superolaterally. So in my estimation, the damage to the labrum here goes from about 1230 to 330 on the clock face, if we're considering 3 o'clock to be anteriorly. And I would call it Seldes type 2 tearing. I would call this an ALAD grade 1, meaning softening of the cartilage over about 1 square centimeter from about 1230 to 2. And my plan then is to perform a elevation of the capsule, a decortication of the rim without any specific rim trimming, and then a labral repair from approximately 1230 to 330, and to perform an iliopsoas fractional lengthening. Then a cam decompression, and importantly, a capsular plication, because we do feel that instability is a part of the pathology here in this case. So comments, gentlemen, on that plan?
Yeah, it's surprising to see this inflammation at the upper part of the acetabular, just behind the, look like some reddish part, just very anteriorly.
Just, you're talking about this?
Yeah.
Yeah, it's pretty remarkable and pretty obvious, isn't it?
Yeah.
Yeah.
Yeah, she was painful for sure.
Oh yeah. Yep, that's what brought her here. Yeah. Andrew, any comments?
No, it seems like a perfect case. Excited to see how this goes here. We just had a couple of questions. Or I guess one question from the audience was asking what preoperative and postoperative functional scores, like PROs, do you get to evaluate your results?
Yeah. So preoperatively and postoperatively, we use a variety of scores. If I had to say which one of them is the best, probably it's the IHOT score. That was the score that was specifically and most recently designed for hip preservation. But we started collecting PROs well before the IHOT score came into existence. So the other scores are the modified Harris hip score, the hip outcome score, and the non-arthritic hip score. Each of them has shown some value in its way. I think the Harris hip score perhaps is the least sensitive and suffers the most from sealing effects, but it is also the oldest and therefore gives us the most ability to compare against historical literature. Non-arthritic hip score better in terms of sealing effects. And then IHOT, again, developed more recently specifically for hip preservation surgery. So what I'm doing right now is I am finding the junction between capsule and labrum, and as precisely as I possibly can, sparing any of the labrum and elevating the capsule. So it's important, looking from this bird's eye view, if I were to come here and start elevating the labrum or elevating the capsule there, I would actually be amputating part of the width of the labrum. So if you do it from this view, it's hard to see because I could be right here. That looks like I'm well above the labrum, but then look what happens when I come to this view. You can see I'd be amputating 3 millimeters or so of its width. So it's important to alternate between the intra-articular view like this and the bird's eye view like this. And then a little later, we'll go to the upper deck view as well, where we put the tip of the scope between the capsule and the labrum and get a view of the junction of the bone where it interfaces with the labrum. So this allows me to elevate the capsule in a very precise way, maintaining the integrity of the capsule, but avoiding any disruption of the tissue of the labrum itself.
Ben, we didn't speak about that, but did you see any posterior lesion, or everything is mostly anterior?
I skipped that, didn't I? So posteriorly, really nothing to speak of. That's posterior superior there and posterior inferior there. So no, I don't see any pathology there. And the rest of the femoral head all looks good as well. Thanks for asking. Yep. And did that answer the question about PROs?
Yep. Yeah, I think that was pretty solid. And that's a great pearl that you mentioned about the bird's eye view and the capsule elevation as well. It looks like you've got a great acetabular leaflet there that you can get a good plication on at the end of the case. Looks like you also have a traction stitch or two in place as well to help with some elevation there.
Correct. Yeah. So I placed a capsular stitch, a capsular retraction stitch on the acetabular side. So here you can see that stitch here. And it basically pulls the capsule away from the labrum to help with identification of that interval. Half-pipe burr. So at this point, we'll switch over to the burr and begin a decortication, remembering that this is, if anything, a case of borderline dysplasia. So we don't want to do a rim trimming, but we want to create neovascularity from the acetabular rim in anticipation of the repair that we're about to do. So this is the upper deck view now. My scope is between the capsule and the labrum. And with this view, I can decorticate the bone and see very well the junction between the bone and the labrum. I can spin the burr in the direction that will sweep the labrum off of that bone, because if we think of the cross-sectional anatomy, there is generally a tongue of bone that protrudes into the labrum. And I don't want to compromise any of the tissue of the labrum. I want to preserve all the tissue I possibly can of the labrum. So using that sweeping motion of the burr, I can be sweeping the labrum off of the bone without compromising any of its tissue. So this is, again, the upper deck view.
That's a great view there. That in this case, wouldn't really be relevant, but you've also published a little bit on labral augmentation, and in terms of your indications for doing that, and how aggressive or not you are with doing augmentation. Again, in this case, looks like there's a good volume to that labrum, so wouldn't really be indicated. But when do you use that?
Yeah, so our thinking has been that the labrum is important. The labrum seals the lubricant fluid in the joint, the synovial fluid. It acts as a stabilizer through creation of a suction seal. So whatever we do in almost every arthroscopic hip case, we want to leave the patient with a good working labrum. And as you mentioned, in this case, I think there is ample tissue of the labrum for a refixation. In some cases where the labrum is deficient, be it because it's calcified or because it's extensively torn, then labral reconstruction has given us an excellent modality to replace a compromised labrum with a graft. And that's also very useful in the revision circumstance after previous attempted repair or debridement. The case that you asked about is what if there is a small labrum or an everted labrum or a deficient labrum where the labrum itself isn't too badly torn to repair, but just may not have enough bulk to it to recreate that seal. And in that case, labral reconstruction has been a consideration. And I think in my practice currently, did I say labral reconstruction? I meant labral augmentation. Labral augmentation today has fairly narrow indications, but certainly can play a role in the hypoplastic labrum. How about you, Andrew?
Yeah, same. And, I think that there's a few talks that you have out there demonstrating a nice algorithm for how to decide. And, for me, it's usually a hypoplastic labrum when the labral tissue quality itself is of good quality, right? Because you're going to be preserving that tissue there. So in terms of what the actual number is, it's probably around 3 or 4 millimeters in terms of the labral tissue size. But I use it fairly rarely.
Yeah.
Yeah. How about you, Fred?
Do you see the inferior iliac spine or not really?
The inferior iliac spine. So I can see it.
Yeah.
If we spotlight the x-rays for a second, I didn't feel on the false profile view that there is overextension of the iliac spine. I'd call that a type 1 AIIS. On the, if you look at the CT, if we could spotlight the CT for a second. Here again, perhaps there's a little bit of rim over coverage focally there, but it doesn't extend up into the anterior inferior iliac spine itself, as far as the CT is showing us. Fred, you do a lot of PAOs, and when we do PAOs here, we have found that sometimes we create subspine impingement because of the reorientation of the AIS. And in those cases, in our PAOs, in a lot of our PAOs, we do a subspine decompression for that reason. Have you found that as well?
Oh, yeah, especially with boy. Yeah, you have to be very careful with that for sure. But here, this is not the problem, but just to people feel more confident where you are, what you are doing. So I think you are working maybe medial to the inferior iliac spine, so maybe more here, no?
Yeah. So we're introducing our drill. And again, I'm back at the upper deck view here. So here I'm seeing on the left side of the screen is labrum, on the right side is capsule, and the bottom of the screen is the bone. So the scope is between the capsule and the bone. And I start my drilling here where I see exactly where I'm planting the drill into the bone. And then I'll continue it here looking at the cartilage surface. And this way I make absolutely sure that we don't penetrate the cartilage surface. So this is important. And we're using a very slender drill. This is a 1.8 millimeter drill. And these will be knotless all suture anchors, which we'll place shortly. So one little trick I've found, if you can spotlight the outside view here for a second, hold there. So here I've got the drill all the way in. Can you spotlight the outside view? The camera? Maybe not. Okay. Not that one. Brian, are you there with us? There we go. Okay, so here I've got the drill all the way into the bone. I can take my drill sleeve and it's got serrations on the end. I can just give it a little bit of a wiggle and make sure it's really well seated in the bone now. And then let's go back to the intra-articular view. Spotlight the arthroscopic view again. And so then my drill sleeve is really well seated on the bone, so my anchor will follow the right path. Suture retriever. I give a little tug on the sutures to make sure that the anchor is deployed and well seated in the bone. And then we'll just retrieve. Let's do it one more time, Ben. The two white sutures are shuttle sutures. So we'll retrieve those. We have the scorpion, please. And we can use a labral scorpion or a variety of different suture passing devices. And I want to see from the upper deck view again where I'm coming through the labrum here, and that I'm right next to the anchor, and that I don't penetrate any of my sutures. And then I can see from the intra-articular view the passage of the suture retriever. And so here, crochet hook. Never mind. Just have it ready. Okay, so now we'll retrieve the end of the shuttle suture, which has a loop on it. And great, Ben, if you can hold the scope, please, with the other hand. Okay, and we'll apply tension here. Side cutter. So one of the nice things about the tensionable anchors is we can control the tension. So we call this the controlled tension anatomic repair technique, where we've passed the suture in a circumferential way around the labrum, but we're avoiding eversion of the labrum in two ways. First of all, by placement of the anchor itself, using the upper deck view right next to the labrum. Here again, you see the placement. And second, by being able to control the tension after the inserter has been removed, we can apply the desired amount of tension so that we get a very rock solid repair, but avoid overly everting the labrum in any way. So same steps here.
Then each time you do a drill for each anchor, you don't drill 4 or 5 hole and then you put anchor in every one once.
Correct. With this technique, we drill each anchor and then place the anchor, drill and place, drill and place.
Okay.
You can certainly do it the other way. You could place all of the anchors first and then subsequently hold the scope, and then subsequently pass them around the labrum. One neat thing that some people have done is place them all, pass them all around the labrum, and then not quite fully tension them all until the end. And then you can go back and retension the previous ones as you go, which I think is a neat.
Yeah, but you have a lot of stitches at the end.
A lot of stitches. Well, yeah, you have a lot of stitches.
Now, sometimes what I do, by example, I do 4 or 5 drill, and I just put 3 anchors, and the other hole is just for keeping some good maybe stem cells that would go outside of the bones through the hole. I don't know.
Yeah. I think it's a really interesting idea, Fred. And I've wondered if we could do something like a microfracture or a micropuncture on the acetabular rim, maybe even instead of decorticating the acetabular rim in certain cases. What do you think?
Yeah. Because people say there is a lot of stem cell just beyond in the bone, so I don't know if it's helpful or not, but
yeah. X-ray. Okay, on this particular anchor X-ray, we can use our X-ray to see that we're well outside the bone. So that's always nice. Here you can see I just make sure my serrations of the drill sleeve are well seated in the bone. And then I'll stay on this upper deck view so you can see the anchor going into the bone mallet and following the correct path.
Distraction was easy or was difficult?
Easy, too easy.
Yeah. It's a good sign. Did you see any instability sign on the femoral head?
I did not. We looked pretty carefully at the ligamentum teres.
Yeah.
We looked pretty carefully at the ligamentum teres. Our thought process has been that if there is instability, it's the ligamentum teres becomes a secondary stabilizer, and because it's subjected to repetitive traction, it eventually can get tears, usually partial thickness tears at first. And so we have viewed the presence of a ligamentum teres tear, a partial tear, as a sign of more advanced instability. And we've actually shown in some of our data that the instability cases that do have ligamentum teres tears do not have as favorable outcomes as those who don't. So this case, in my view, is an instability case, but we're catching it at a good time before the instability is too advanced, and hence I would view the prognosis as very favorable.
So we don't see any more of the inside view.
I'm sorry?
We don't see any more of the inside view. It's completely white.
The inside view went away. Oh. Wand.
And then Ben, just a question from the audience in terms of what are your considerations or your indications for opting for, they put a sublabral or translabral suture, so probably a circumferential versus a labral base type fixation.
Right. I'll answer in just 1 second. Megan, are they working on the restoring the end? Oh, it's back. Okay, good. Thanks. You guys see the inside view again?
Yeah,
Yes.
it's perfect. Very good.
Okay, super. So indications for a labral base refixation versus a circumferential fixation with the controlled tension anatomic technique. The labral base refixation was a technique that we developed going back to about 2008, 2009 to accommodate for the technology that was available at the time and to allow us to restore the seal of the labrum against the femoral head. So this was at a time when we had adapted open techniques to arthroscopy. And one of those open techniques was labral takedown, acetabuloplasty, and labral refixation. So in a majority of our cases, we would take the labrum down off of the acetabular rim and separate it from the cartilage, usually with a beaver blade. Then we would do the rim trimming, and then we would do an acetabular refixation of the labrum. And in order to refixate the labrum in a way that would reproduce its seal against the femoral head using technology available at that time, the circumferential sutures would often pull it away from the femoral head and were problematic. So we developed labral base refixation to restore that seal, again, using the technique and technology available at that time. A couple things have changed since then. One, we have largely moved to labral refixation without labral takedown. And so as in this case, where we've kept the chondrolabral junction intact, that anchors the labrum to a degree and resists over-eversion. Secondly, we have had the advent of knotless tension-controlled anchors, such as the ones we've used here, and where we can control the tension on the anchors, we can avoid that kind of over-eversion. So in a moment, we'll take traction down and we'll look at the seal of the labrum against the femoral head now that we've completed the repair here. So I'm happy with how the repair has come out, and I don't see a need for further anchors. We've repaired the entire area that we delineated in our plan as torn and in need of a refixation. So I'll come right back to the question of the repair technique when we take traction off. I want to spend a moment on the iliopsoas lengthening portion. May I have a switching stick, please? So here we're going to come through the anterior portal, half pipe and beaver blade, and we're going to come in with the beaver blade. And at this portion, we are not going to elongate the capsule, the capsulotomy. I think that's one source of problems, is elongation of the capsulotomy. Instead, we're going to come over the capsule, so anterior to the capsule here, and we're going to work our way into the iliopsoas bursa in a non-invasive way, and we're going to do our lengthening superior to the level of the joint line, so that we avoid doing a release, but rather achieve a lengthening. So here we're seeing cut fibers of the iliopsoas, and just one more fiber there. Okay, so that is the end of the iliopsoas. That's the cut end. You can see that above us is plenty of muscle. All the red is muscle. We're leaving all that intact, so we don't touch any of the muscle. And at this level in the iliopsoas fossa, above the level of the joint line, the iliopsoas is less than 50% tendon and more than 50% muscle. So by just nicking the tendon and leaving the muscle, we achieve a lengthening, but not a release. And we've also left the majority of the bursal sheath intact by just making a small poke hole incision to get into the sheath with the beaver blade and with the scope. So we'll come back out of that small poke hole that we made there, and you can see we didn't touch the capsule at all. So I think this technique is perhaps quite different than a iliopsoas release lower down, whether at the level of the joint line or closer to the lesser trochanter, which may be more likely to cause weakness and or aggravate instability. So this will obviously be a topic for some more conversation as well. I'll take traction off now, and we're going to see the femoral head at the bottom of the screen re-enter the acetabulum at the top of the screen. And now we can see a very good seal. So this is what I call the money shot, where we've taken traction off and we evaluate the seal of the labrum against the femoral head. And I'm very happy with that seal throughout. So we, if I saw that there was a gap between the labrum and the femoral head because of eversion of the labrum, then that would worry me because the labrum can't do its job if it's not in contact with the femoral head. But here we see good contact throughout. So let's go ahead and flex back up, flex all the way up now. And interesting finding here. This is what we call a divot sign. So I want to spend a moment and ask you guys if you've seen that. This is not a chondral defect. You can see that it's an old finding, likely a remnant of physis. And we tend to see this divot sign in people who have instability. It tends to be a little bit more proximal, actually, than where the cam is. So we don't necessarily follow it with our femoroplasty. It can be tempting to do so, but often this is not where the cam lesion is. So I don't know that anybody's exactly figured out what is the correlation between the divot sign and instability, but multiple authors have observed it. Any comments on that, gentlemen?
Yeah, usually you see that a little bit lower.
Less Trendelenburg, more airplane. I'm sorry, say again?
No, this is very spectacular. And sometimes I see some kind of stuff, but a little bit lower on the femoral head, but the hip is flexed, so maybe it's the same position as usually.
Yeah.
But this one is big, huh?
Yeah, it's a pretty good size one. Any theories on what makes that?
No.
Switching stick? Me neither.
Not sure. We have a couple questions from the audience. One is asking if your rehab protocol changes when you do your iliopsoas lengthening, or if you keep your same standard post-op protocol.
Yeah, it actually doesn't change at all. Same protocol. Mm-hmm. I've just switched to a higher flow cannula in anticipation of the fact that I'm about to do a femoroplasty here. So what we're going to do next, I've got the scope in the anterolateral portal, and I'm putting half pipe slingshot, and I'm putting a retraction stitch through the Dalla portal now. And this retraction stitch is going to pull now on the femoral side of the capsule to give me a little bit more space. This is, I find, helpful, given that we're not doing a T capsulotomy or anything. Okay. It'll give us a pretty broad exposure. Sorry, Fred, you were going to say?
No. I just want to say you did an intraportal opening of the capsule.
Interportal, yes, correct.
Yeah, no T. Yeah.
No T. Yeah.
Okay.
Yeah, and obviously, I don't see anything necessarily wrong with a T capsulotomy as long as it's repaired. But in most cases, I have not found it necessary. So this is a case where there's more than one good way to do something. But the way that I've typically done it is without a T capsulotomy. So at this point, we can look at the visualization that we get. It's a pretty broad visualization of the femoral neck and head neck junction. We can go all the way anteriorly and medially. That's the medial synovial fold in the center of the screen. Above it is the zona orbicularis of the capsule. We can even go well past it, so we can get posteriorly to the posterior inferior segment of the femoral head and neck. And then working laterally, we can get in this position quite lateral all the way to the lateral synovial fold. And to go further posterior superiorly, we can go into extension, and we'll do that a little bit later. I'll close the CT scan now, and I'm going to we'll utilize our intraoperative fluoro X-ray there. Okay, good. And there, X-ray. Okay, so here we can draw what we estimate to be the alpha angle.
And a couple questions from the audience, if you have a sec. One was,
Yep.
With the psoas lengthening, would you worry about instability in this patient?
Yeah, so I'm absolutely worried about instability in this patient. I think that that's one of the fundamental underlying pathologies. X-ray. I think if some of the historical cases that have had troubles, perhaps the capsule was left open if there was a capsulotomy, or in some cases, parts of it were shaved. And that may have actually compromised the stability. If the labrum is not producing a great seal against the femoral head, that could compromise the stability. So far in the case, we have restored the labral seal in a way that we've seen we're content with. So that's at least one static stabilizer that we've maintained or perhaps improved. The second is going to be the capsule. So if our primary pathology here, or primary pathoetiology, is instability, augmenting the stability through tightening of the capsule may help restore primary stability. The situation where there is not primary stability due to compromise of the labrum and perhaps attenuation of the capsule is, in my view, the situation where the iliopsoas becomes a secondary stabilizer and a meaningful one. And in that case, the iliopsoas likely becomes hyperactive, and a hyperactive iliopsoas may snap and may cause painful snapping. It's hyperactive because it is trying to act as a stabilizer when in a normal hip situation, it should not be acting as a stabilizer. So our thesis is that if we can restore primary stability, get another fiber wire, please. If we can restore primary stability through tightening of the capsule and restoration of the labral seal, then the iliopsoas should no longer have to function as a secondary stabilizer. And in that case, then we can do a lengthening. Again, I would emphasize a lengthening, not a release. Release can be worrisome. With this combination of procedures, we've not experienced aggravation of instability. So certainly I think about it, and that's how we thought about it. Andrew, you've done a lot of thinking on this topic as well. Do you want to share some of your thoughts?
Yeah, I think I've adopted that same type of thought process. And as you mentioned, we published a paper on this, looking at athletes at midterm, so 5-year minimum outcomes, looking at a group of athletes that had undergone the iliopsoas lengthening compared to a control group who had not, and showed similar results in those patients. So, and I think that's the type of patient, a good type of patient to look at. That's going to be a little bit higher demand where you may be able to spot those differences, but we still had similar results. So I agree. As long as I think you follow a good technique, maintain a good acetabular capsular leaflet, get a good capsular application at the end, I think you'll be okay. I think we can run into troubles if you do a complete iliopsoas release, and or if you don't get a good capsular repair or application at the end of the surgery.
Right, right. And many have issued words of caution on this topic, and I would echo those words of caution. I think if just like you just said, if the iliopsoas is released rather than lengthened, if the other sources of instability are not addressed, then you can run into problems. So I would certainly approach it with caution. But again, one of the reasons I chose this case, because I know this would be an area of interest for everybody. Fred, what's your take on iliopsoas lengthening?
I've done mostly when there is a hip total hip replacement, but I've never really done what you have done today. So I have no special, I don't know anything about that, so I won't say anything. Sometimes, don't you see sometime on the entire part of the femoral neck, a huge synovitis that sometimes may be also a problem?
A synovitis in the psoas U?
Yeah, no, just in front of the femoral neck, just at the head-neck junction. Sometimes you have a huge synovitis in those cases. It's something else.
Definitely.
Today it was a little bit, so this is why maybe you start with the vapor before rimming, or just you use the vapor to give you the landmark.
To use what again?
I think you use the vapor to put some landmark on the bone, and also to remove this synovitis just on the femoral neck at the head-neck junction. And in some patients, you have very thick synovitis at this level.
Yeah, I think that's a really interesting point, Fred. And what I've removed with the radiofrequency there was periosteum over the femoral head-neck junction in preparation of the femoroplasty that I'm doing right now. Sometimes I've certainly seen synovitis. I've also seen damage to the periosteum where it looks like it's even torn. The periosteum is torn. And I think that is something we haven't talked enough about, because we know that periosteum has nerves. And if we see, and we know that the periosteum in the area of the cam can impinge. So if that periosteum is impinging and is torn, then I would think that the periosteum itself is a cause of pain, not just the labrum. So by removing the periosteum and then correcting the deformity, it's our aim to address that. But I think that's something that hasn't been talked about enough as a potential source of pain in our field. What I'm doing right now is carefully reshaping the femoral neck, and our approach to femoroplasty has been to aim for a perfect sphere. I think this was done really from the start with the open FAI treatments with surgical dislocations that Reinhold Gans pioneered. They used spherical templates to aim for that sphere during the surgery, and I think did a beautiful job with it. I once asked Reinhold Gans why he used a chisel rather than a burr, and he said, "Did Michelangelo use a burr?" Good answer. We do use a burr, obviously, arthroscopically, but I think some of the techniques that evolved over the years went a little bit away from that spherical target, and we've maintained here in Chicago that spherical target throughout our evolution. And I think because of our origins in open surgery, and are targeting that using fluoroscopy. So fluoroscopy gives us a view of the entirety of the globe of the femoral head, which is better than our arthroscopic view here in terms of understanding the shape, but it's still a two-dimensional view. So we have to use fluoroscopy from a variety of different perspectives, from a variety of different angles, in order to understand that we've actually created a sphere, if that is indeed our target. How have you guys thought about that?
It is some little cyst, just what you are burying.
Yeah, it's a little sister, exactly.
It's good. That I love to see that, because you are exactly where is the problem.
Yeah, it sort of gives us maybe a little bit of an affirmation that cam impingement was at play, right?
Yeah.
Absolutely.
X-ray. Okay, so we're working our way toward our optimal shape here. You can see that on the X-ray view. And right now, the X-ray view that we're working with is essentially a done view. So we're focused on about 1:30 to 2 o'clock on the femoral neck. And we'll aim for a sphere here, and then we'll move to views that give us an X-ray view at 3 o'clock and 4 o'clock. And then we'll go laterally to 1 o'clock, 12 o'clock, and 11 o'clock. So I'll show you those in order. So ultimately, we will have had fluoroscopic views at a minimum from 11 o'clock to 4 o'clock on the femoral neck.
And this touches on one of the views from the audience in terms of, one, they ask if you use any traction sutures for this view, and looks like yes, you do, coming out the Domb portal. And then they ask how proximal and distal do you resect on the cam, and do you use intraop views versus your 3D model for doing so? But it sounds like it's a combination of your intraop view with the camera combined with your fluoroscopic view on multiple different positions.
Yeah, exactly right, Anna. Exactly right. The CT beforehand and X-rays beforehand give us an idea of what we're up against and what we're going to need to do during the surgery. But during the surgery, we're using intraoperative, arthroscopic, and fluoroscopic views simultaneously to assess the reshaping that we're doing.
Another question we had was if the same technique for iliopsoas tendon lengthening could be used in the setting of a total hip arthroplasty or replacement, and if that's what you do in that case.
Yes, great question. What was the question about, during a total hip or after?
After, for the, I presume after for treatment of iliopsoas tendonitis.
X-ray, right. So this is an area that I think most of us, most of you on this Zoom actually know about iliopsoas impingement after total hip. The joint replacement community, the arthroplasty community, does not know about this as much as they should. And I think it's a relatively common cause of pain after total hips, and maybe even a more common cause in the anterior approach, perhaps reaching as much as 5 or 10%. So we can use this technique with after a total hip to do an iliopsoas lengthening. I'll talk a little more about that, but I just want to point out the X-ray view. Now we've gone from an alpha angle of 62 degrees to 43 degrees on our done view. So now we're going to go to our second position, and you can see on the X-ray that we've maintained what I would view as a spherical contour X-ray there. So now we're looking at the 3 o'clock position, maybe even closer to 4. We'll let the knee out a little bit and X-ray there. So there we're getting to 4:30 or 5 o'clock, and we're seeing that is all still spherical. So there wasn't any deformity in this region, so that's not an area we're going to have to do any work. We'll come to extension now and go to 10 degrees of CG. Now we're going to take the X-ray to the 1 o'clock position, anterosuperiorly. Again, I don't expect much deformity here based off our preoperative planning, but I want to look at it fluoroscopically. And actually, there's a little more deformity than I expected. Go ahead, Gene. So there you can see a little bit of deformity still exists. And let me, I'll actually turn this off so it's easier to see. So there, superolaterally, you can see a little bit of deformity. X-ray here, I'll put my burr on it. That's the area that I still want to do a little bit more work.
Ben, well, I can see that you always calculate the alpha angle. This is intelligence artificial system inside the C-arm?
Yeah, so that's a software that's used as an overlay. And I think there are a variety of softwares now that can be used as overlays to calculate the alpha angle. Generally speaking, I'm targeting an alpha angle somewhere in the low 40s. And I pretty much am looking for that all the way around the circumference of the femoral head neck junction. Obviously, there are specific cases where somebody has femoral excess anaversion or retroversion that may change our thinking about what alpha angle we're aiming for. But regardless of what alpha angle I'm aiming for, I'm essentially always aiming for a spherical contour.
And when you use
And then question from the sorry, go ahead.
when you use the burr, you always go forward, or sometimes you go also reverse to
Good question. Yeah, so right now I'm on reverse. I'll tend to alternate between forward and reverse to get clean margins with the soft tissue. So here you see I have a little bit of fraying when I was on reverse. So I'll change to on forward and then clean that area of fraying on forward. X-ray. So I find that helpful to create those nice margins. Let's go to 0C now. So I've got a spherical contour now on that view, and now we'll go to 12 o'clock position. X-ray there. Good. Maybe very, very slight more recontouring superolaterally, but I'm getting pretty darn close to where I'm happy with this. And so I'm on reverse again here now. Andrew, you said there was a question?
Yeah, question here, just asking where you think the cam is most commonly missed, if it is missed, and probably it's in this kind of posterior lateral superior area, I would imagine.
X-ray? Yeah, I think that's right, Andrew. So now we've completed all of our views. I'm going to just make sure we're nicely refined and smooth here. And so I really like our contour here. We will now take the X-ray out and let's flex back up, and we're going to go to our capsular plication. We'll take 2 switching sticks, please. That come all the way out of it?
I don't know if we have the question, but this lady is a special sport, or she don't do sports, or?
Can you repeat the question, please?
She's young lady, does a special sport, or she do, I'm saying, nothing special?
Yeah, so we see a lot of these in gymnasts, dancers, cheerleaders. I think the people who have instability tend to be in sports like that, and I'm not altogether sure whether the sport causes the instability or whether you have to have some level of instability to be any good at dancing or cheer or gymnastics. So maybe it's self-selecting. Maybe it's the young ladies who have instability and loose ligaments who wind up doing those sports in the first place. Or maybe it's some combination of both.
Yeah.
What do you think?
Yeah. I never seen the dancer with a protrusio.
Do you have cheerleading in France? Is that a thing?
Not much.
No cheerleading. But you've seen them in the movies, right?
Slowly starting. But I never see one. I never see one for hip scope.
In the movies?
Yeah, in the movies.
Yeah. Fred, as you know, Shaver, please. As you know, I grew up in Canada, playing basketball in Canada, and I never saw a real live cheerleader until my first college game in the States. I'd only seen them in the movies.
It's starting in basketball. Sometimes you see some during the pause. There are some cheerleaders.
Yeah. So here we're just going to elevate the muscle off of the capsule here, and notice where my shaver is pointing. It's pointing down toward the capsule, so I'm not shaving any muscle. I'm just disconnecting the suspensory fibers there between capsule and muscle. This up here, this is the rectus femoris indirect head. So I'm sorry, here is the rectus femoris indirect head. So we'll leave that alone. And this here is iliocapsularis. And again, we'll leave that intact too. So here we'll bring our cannula into the joint. And then similarly, we'll do the same thing, let the knee out a bit. We'll do the same thing on the femoral side here. So just disconnecting the suspensory fibers there.
So now I just understand if you want to be a very good hip scope surgeon in America, you must come from Canada.
Well, Dr. Jimenez is the exception.
Yeah.
Thanks. Question from the audience from earlier that I missed was indications for ligamentum teres reconstruction. Obviously, I don't think it would be indicated in this case, given it was intact, but your thoughts on that in general?
That's a juicy question, isn't it?
Yeah, it's a loaded question.
Hoping that would come. So I think we've actually developed a very good technique for ligamentum teres reconstruction. We've published that technique. I'm very happy with it from a technical standpoint and a biomechanical standpoint, and our ability to reproduce the normal anatomy and mechanics of a normal ligamentum teres with an allograft. Now, having said that, a little less clear is in whom should we do that? And here I think this is still an emerging science. So our indications have been very narrow, very conservative, I would say. And we have largely restricted it to people who do have full thickness tears of the ligamentum teres and have clear other reasons for instability. And frankly, mostly in the revision circumstance where they've had failed previous treatment of instability. I've spent a lot of time with John O'Donnell. He and I have collaborated on this quite a bit and have had fairly similar indications, I would say. He has perhaps expanded them a little bit beyond that, but mostly I think our indications have been fairly similar. What do you guys think?
Yeah, when I have to fix a ligamentum teres, I do a PAO.
Sorry, say it again, Fred.
When I have to fix a ligamentum teres, I do a PAO, and that's faster.
PAO, yeah. It's fast.
I never done that. When you see Gons, who was killing every teres ligament at the end of his surgery, I don't know if it's, I don't know. I have no. It seems interesting, but I don't do that. I do PAO. You use Vicryl, you use Vicryl, you don't use resorbable.
Right. Yeah, good observation. So these are Vicryl sutures. Over a decade ago, I had some cases where permanent sutures had caused granulomas or a nidus of scar tissue, or in a few cases, even a nidus of heterotopic ossification around the knot. So I went away from permanent sutures at that time, and I haven't had that problem again. To be fair, I think there have been some newer versions of permanent sutures that may be a little lower profile, that may have that problem less. Let the knee out of it. So it's possible that could be revisited. At this point, I've been doing it this way for so long with the Vicryls, I'll probably keep doing it. What I'm doing here with the plication is we are imbricating the capsule and also setting up a capsular shift. So our bite here is on the acetabular side at a certain point, and then you can see the obliquity of the suture. So the suture is here on the acetabular side and obliquely goes to the femoral side. So on the left of the screen is more inferior, on the right is more superior. So since we're more inferior on the femoral side, this will create a capsular shift. And when we perform a capsular shift, it will augment the screw home effect of the capsule, which causes it to tighten in extension and to resist external rotation and anterior translation. Suture treatment. So each of these sutures, we calibrate the size of the bite for the imbrication and also the obliquity for the capsular shift. And so here we're placing our 5th suture. So with 5 sutures, we get a very, very robust capsular plication with an inferior shift. Even if one of these sutures were to break or pull out, I'd probably be fine with 4. But I do think we need at least 4 in this case. How have you all approached the capsular closures and plications?
Same way from my standpoint, 4 or 5 sutures in oblique fashion for the shift. Usually I do it about 30, 45 degrees of hip flexion in a similar fashion, and pass all the sutures first and then tie all of them sequentially at the end. Any risk of tightening and over tensioning or over tightening in your opinion? I guess if you had too much obliquity on the stitch would be one potential mechanism for that.
I think conceptually it's possible. In practice, I really haven't seen it. We did do a study on range of motion before and after plication and found that the only detectable change in the range of motion was in external rotation, an average of 11-degree decrease in the range of motion on physical exam of external rotation. But clinically, the patients didn't notice it and didn't complain of it. So we've considered it something that we can detect perhaps on exam, but not a clinically significant decrease in the range of motion. So there you see, we've placed 5 sutures and we've placed them all with that same obliquity and that same imbrication. And now we'll tie them from medial to lateral. So we placed them from medial to lateral. Now we'll tie them from medial to lateral. So we'll come in here with the suture retriever. This is a little trick that I think is a nice little pearl. I call it the X grab, and this was actually given its name by the great Dr. Andrew Jimenez. So it's worth highlighting. So we've grabbed the sutures in an X formation here with the suture retriever, and then when I pull them out, this allows me to know which suture is which, and I'm going to use the acetabular side as the post. And it also allows me to know that there is not any twist at all in the sutures. So I don't have to go looking inside the cannula and see if it's twisted. I already know it's not using that X-grab technique. So big credit to Dr. Jimenez for identifying that and giving it its name.
That might have been Taylor Harris, but I'll take the credit on this webinar.
Oh, was it? I thought it was you. All right. Maybe my memory is bad.
Yeah.
All right. So maybe we can come to spotlight the outside view for a second. Okay, and so spotlighting the outside view now. I'll do the same thing, but this way you'll just get to see it from the outside view. So we'll do our X grab here, and then as I pull these out, I know which suture is which. So this is the acetabular side of the suture, and I'll use that as my post. And we'll tie that. I use a Tennessee slider, so AABA. Can I have one more suture? One more vicro, please. And go back to the arthroscopic view. I'm going to place one more suture in that spot. I didn't like how that one was going down. Anyway.
Ben, just a question from the audience in terms of during the femoroplasty, caring for vascularity of the femoral head when working, really posterior laterally, and they're asking if there's a limit for how far you would go before considering an open approach. And I know you published on the circumferential femoroplasty arthroscopically. So, any comments on that?
Yeah. So, and we used to do a lot more surgical dislocations than we do today. So we did that with the trochanteric flip osteotomy and dislocating the femoral head. It allows for a tremendous exposure, and it's really a very elegant technique, I think, for exposure of the entirety of the hip joint. And I think its use has somewhat diminished over time because the arthroscopic techniques have improved. So as we've improved these arthroscopic techniques, there's been less and less need for the surgical dislocation. And we've been able to address a majority of these cases arthroscopically. As you pointed out, circumferential femoroplasty would be, I'd say, the hardest femoroplasty to do. And even that femoroplasty at this point, we can really do arthroscopically. So there's still roles for surgical dislocations, I think, in cartilage procedures such as osteoarticular transplants, in deformities with a short neck, like in Perthes disease, where we want to do a relative neck lengthening. Those might be some of the major roles for a surgical dislocation in my practice today. But it certainly has been somewhat supplanted by the arthroscopic techniques. Having said that, I think there are some facilities where there's a tremendous experience with surgical dislocations, and the comfort level with doing those complex procedures through a surgical dislocation and the skill set may be better adapted to doing it through an open approach. And in that case, I would much rather have an open surgical dislocation and a great correction of deformity rather than have an arthroscopic surgery with a less good correction of the deformity. So I think I would really prioritize the correction over the approach.
I used to do 10 hip dislocation a year. Now I do maybe 1 or 2, no more, and especially only when I want to lower the greater trach. Very useful for me now.
I have to say I miss it because it's such an elegant approach.
Yeah.
But I've had the same experience, Fred. So we're tying again medially to laterally. This is number 4. And you know, I view this as a really key part of the procedure. There was a lot of early data on patients with borderline dysplasia that showed really disastrous outcomes. Jay Parvizi published one of what I would maybe call a landmark study showing very poor outcomes in that patient population. A majority of those cases had a capsulotomy that was either left open or partially debrided. Some of them had labral debridements as well. So perhaps what was happening is the instability wasn't getting improved by the procedure. And in some cases, maybe the instability was made worse by compromise of the capsule on the way in and out, or by compromise of the labrum because of doing the necessary labral debridement for the tear. Hold the scope there. So when we first undertook to treat this challenging patient population, the goal was to change the paradigm, and in lieu of what had been done in prior series, to not only repair the labrum but also improve the stability of the joint through this capsular plication with inferior shift. And we first published a pilot series of patients who had CEAs between 20 and 25, and found successful results. This is going back to the early 2010s, and then have since then greatly expanded the indications as well as the clinical experience in this patient population. So it's really given us modalities of treating a patient population that previously may not have had a great answer. Here's our completed capsular plication. You asked about over tensioning. One thing we'll do now is we'll come into extension slowly, and I want to just watch these sutures as we bring the leg into extension. If I've over tensioned to any significant degree or created too much of a shift, those sutures will pop open at this time point. They're vicryls, not permanent sutures, so they can pop if they're under too much tension. And I'd rather know that now if that's going to happen. But as you see, they hold intact, and we have a very good capsular plication. With that, maybe we can shift back to to spotlight the outside view here, and I'll step into the frame. All right, if you can zoom out there we go. Okay. It's been lovely sharing this with all of you. Any concluding discussion points, gentlemen, that you think we should go over?
I think it was a beautiful surgery, Ben. You do something fantastic. It was just perfect.
Thank you so much.
And you have to congratulate your team, but just follow you as fast as you are.
Well, I wanted to make sure everybody gets out in time to see the eclipse.
Yeah, outstanding job, very elegantly done, and certainly can be a controversial procedure. I think, done in this fashion with capsular preservation, plication, and a controlled lengthening of the psoas, I think can be a very helpful technique in your armamentarium.
Thank you. Well, again, I'd like to thank our staff here, and Megan and Brittany and Nancy and Dr. Coons being with us. I'd like to thank Proximy and Brian and all the good folks there who have helped with the technology. And it is wonderful technology that allows us to broadcast in this way. And finally, big thanks to Caroline for organizing. She's coordinated so many people in this effort. And thanks to Dr. Laude and Dr. Jimenez for your expertise as moderators in this session. I really do appreciate it. And enjoy the eclipse, everyone.
Yeah, the quality of the movie was just perfect. Everything was perfect. Nothing else to say. Thank you, Ben.